Hip flexion, the patient is supine. Your access is going to be the lateral aspect of the pelvis and the thigh. Basically, you're trying to look for that greater trochanter once again. Your proximal is going to be the midline of the pelvis and the midline of the trunk, and the distal is the midline of the femur going down towards the epicondyle. And I know sometimes people have difficulty holding the goniometer, and so they'll use one hand and they're pressing it not flexible, but we can keep this in the straight position here. So we start off in this position and we ask the patient to bring their knee towards our chest. And we realign, make sure we are in proper alignment before we take our measurement. You can see my proximal arm is off. So here we're taking our measurement in this position. And we have 120 degrees. And then I'm going to do my passive motion here, retake my measurement. And then I'm going to come up and give my little extra, take up my slack and my physiological, give my little extra push for my end feel. In this case, we have a soft end feel because of the soft tissue approximation in this region. Normal range of motion for hip flexion is 120 degrees. Hip abduction and adduction is performed in a supine position. My landmarks are going to be the ASIS, is where my access is going to occur. My proximal arm is going to be on an imaginary line between the two ASIS, and my distal arm is going to go down the midshaft of the femur. And what I'm going to ask the patient to do is to slide their leg out to the side. You may have to help them along a little bit. And you're going to get up into this measurement here. And then, of course, you would do your passive range of motion. See if they can go a little bit farther. Come back towards the middle, and I'm going to show you on this side how we are going to do the end feel. So again, I can use ASIS, the imaginary line. So as I come out, I need to make sure that I'm reading the proper scale, and I'm reading my red scale. In this particular case, we're at 35 degrees. I can do passive. We're going to go up to 45 degrees. Again, I need to stabilize the hip, and I want to be supporting the patient's leg and have them relax for me so I can get a good end feel. So I'm stabilizing here at the pelvis above the hip and take up the firm, and again, I'm going to have a firm capsular end feel. Normal range of motion for hip abduction is 45 degrees. Now, hip adduction, they're going to be coming across and bringing their leg this way, and I have something in the way here, which is the other leg. So I have to ask the patient to abduct this leg before we start performing adduction. Landmarks are the same. ASIS, imaginary line. I'm going to draw my proximal arm across that way, and then my movable arm down through the midline, and then I'm going to ask the patient to move their leg towards their other leg. And take my measurement here, do my passive range of motion, retake my measurement. Again, for my end feel, I need to stabilize the pelvis. So I want to come up here above the hip joint and stabilize the pelvis. Use that nice long leg as a lever arm and do my end feel. Normal range of motion for adduction, 30 degrees, and my end feel is firm. Hip extension, our landmarks are the same as hip flexion. We have the greater trochanter, we have the midline of the pelvis up towards the thorax, and then we have the midline of the femur. And so this is our starting position, and we're going to ask the patient to lift the leg up towards the ceiling. And you may have a lot of patients, especially if they got tight hip flexors, this is going to be very difficult for them to get into this position. And we're going to take our measurement here, which has got 30 degrees. Then we're going to have to do our passive motion. And the thing that we have to be careful here is we don't want the pelvis coming too high up off the table. They should keep their ASIS on the table. So if you see someone arching up in this position, that is incorrect. They are coming up way too high. They need to make sure that they keep their pelvis here. And so now we took our passive range of motion, so we have to do our end feel. Again, for the end feel, probably need to grab around so that you can help support this leg and your patient is not holding it up. So I've got the lower part of the leg trapped against my body, and I've got my other arm here. I'm going to put my stationary hand here on the upper part of the glute, of the gluteals, and I'm going to come up and do that end feel in this position, and this end feel should be firm and capsular. Hip internal and external rotation in a sitting position. And your access here is going to be through the mid-pole of the patella, through an imaginary access up the shaft of the femur. Because remember, internal and external rotation is actually taking place at the hip, but we aren't able to measure it close and directly, so we're using this access that is coming through the entire shaft of the femur. So there's my access, my stationary arm, just like for internal external rotation in the shoulder, can be perpendicular, being upright. It can be perpendicular to the floor, pointing down, or it can be parallel to the floor in this position. Again, here I'm starting at 90 degrees, and so I need to make sure I'm reading the correct scale. So in this case, I'm going to keep my proximal arm perpendicular to the floor, and my movable arm is going to be the mid-shaft of the lower leg and along the tibia. So for internal rotation, I'm going to ask the patient to bring her foot up towards the ceiling this way and make sure that I'm keeping that mid-pole of the patella and the shaft of the femur, and that I'm keeping the movable arm along the mid-shaft of the tibia, and I'm going to take my measurement here. Then I'm going to put her into a little bit of passive stretch, and then when I go for my end feel, I need to stabilize close to the pelvis here, or close to the hip, using the leg as my torque. I'm going to then assess the end feel, which is firm. 45 degrees of range of motion is what I'm looking for internal rotation. For external rotation, I'm going to ask the patient to bring the foot in this direction. Still have perpendicular here, same anatomical landmarks. Take my measurement here, do my passive range of motion, and then again stabilize close to the pelvis here, and go ahead and do a end feel. 45 degrees is normal range of motion, and the end feel is firm. An alternative way to measure hip internal and external rotation is in the prone position. And we start with the patient in prone and with the knee in flex to 90 degrees. Our landmarks are the same, going through the anterior aspect of the patella so that it is an access that goes up through the femur. We're going to use perpendicular to the floor, and that could be with the proximal arm up or down. And then our movement arm is going to align with the mid-shaft of the lower leg or the tibia. And in this particular case, we've got external rotation coming in this direction. So we're going to go through that midline here of the shaft and align our goniometer properly. Make sure that the proximal arm is perpendicular. So we're going to do our active, our passive, and then for the end feel, we have to stabilize proximally, more at the knee, more at the hip, and we're going to take up the slack and give our stretch for our end feel, which is firm. We have 45 degrees of external rotation. For internal rotation, I'm going to ask her to move out in this direction and take our measurements again. Line up properly here. And then we're going to come with extra, and then do our end feel once again, and we can stabilize here closer to the hip. And we're using this long torque arm now, so you have to be really careful that you don't put too much force in through there. In this position, we can also check the hips for anteversion and retroversion. And what we're going to do is we're going to have the patient internally rotate at the same time. And what you're looking for is whether or not the legs are the same. And you can see we actually have a little excessive on this side. And then you're going to ask them to externally rotate, and you're going to be looking to see with that retroversion or that introversion. One of the other things that you can do too is palpate for the greater trochanter, and you want to make sure that the greater trochanter then is in a neutral position, coming out directly to the side here. And you can see that the foot is slightly in external rotation, and this is normal. With anteversion, once you find that proper position for that hip, you're going to find that they're going to be a little bit more in internal rotation rather than external rotation, because they're more internally rotated because of that position of the femoral head. And with retroversion, you're going to find that they're going to be a little bit more in that external rotation.